All right. So, my name is Bob Valente. I'm an arthritis doctor at the Arthritis Center in Nebraska. We got seats up front. They're the only ones left now. Come on up. And we're going to talk about something. The last time I gave one of these talks, like 2 people showed up. So I thought maybe I'll make a very interesting title and see if we can get more people to show up. I hope I don't bore you to tears talking about something that you weren't expecting me to talk about, because I don't know what you thought about. What did you think arthritis that is really in your head meant? You guys can tell me what you think it meant, but I'm trying to play on the idea that there really isn't an arthritis. In the old days, people used to have issues of pain, and we'd say, it's really in your head. That's not a very nice thing for doctors to talk about. I'm going to talk about an arthritis that's really in your head today, and it's called giant cell arteritis. And arteritis means artery inflammation. Okay, so that's where that term comes from. And giant cells are the kinds of cells they see under the microscope. Now, really, there's 2 really closely related diseases. One of them is that giant cell arteritis, and that, if I keep using these big words, we'll be here all night. 4 sheets right up front. And the other disease is called polymyalgia rheumatica. We're going to call that PMR, because again, if I had to use these big words and say them all night, we'd never get out of here. So they are very closely related for a couple of reasons, and we're going to talk about what those reasons are. But this basically represents an inflammation of the lining of blood vessels. That's what arthritis doctors really are. When you see a rheumatologist, they are specialists in the inflammation of the lining of things. The lining of the joints, obviously, the lining of blood vessels, the lining of the heart and lungs. Those are the things we deal with. That's what our training is in. We got 2 seats here, 3 seats here. Come on up, guys, because otherwise you're going to get tired standing out there. So, so these are the terms. They don't mean anything to you yet. Hopefully they will at the end of the day. When we talk about giant cell, GCA and PMR, these are actually really common diseases in this part of the world. It's not as common in Italy or South America or in Africa. It's much more common in northern United States and also in Europe. And when we talk about PMR, you don't realize this, but it's that disease, PMR, is second only to rheumatoid arthritis in frequency. So we see a lot of it. Yet, how many people do you know say, I've got PMR? Not very many. They say they have arthritis a lot, or even rheumatoid arthritis. But PMR is more common in people over age 50 than rheumatoid arthritis. So you're going to get to learn a little bit about a disease that's pretty darn common, but you just didn't know it was there. Now, giant cell arteritis, or temporal arteritis, is by far the most common inflammation of blood vessels. So we're actually talking about things that are pretty common. And it occurs in the same patient population. And interestingly, of the people who have PMR, 15% of them have GCA, and over 40% of GCA have PMR. Now, there's just a lot of overlap between these 2 diseases. And they happen in the same group of people, and you have to be over age 50 to get this. So what a lucky deal, right? Only age 50 or older. And there seems to be a season, and it cycles every 3 or 4 years, and we're in the season right now. I am seeing a lot more PMR and GCA than I normally, than I did a year ago. Now, we're talking about a population of Scandinavians and Northern European descent. That population. So that's why around here, or in Minnesota, and places like that, we see a lot more GCA than they might see in Mexico, for instance. We see about 33 per 100,000 per year that are all over age 50 years old that come up with this giant cell arteritis, or GCA. And Japanese, African Americans, and Asians, there's very few of them that actually get it. It's basically 300 times less common in that population. If you have giant cell artery, if you have a person who you think might have PMR or GCA, it's more likely PMR if you are younger. In your 60s, there's only 1.5 cases per 100,000, and by the time you get into your 70s, there's quite a bit more. There's 12 times more GCA. So as you get older and older, it gets more and more common. Women outnumber, just like in most every arthritis there is, women outnumber men. So it's the same population with PMR, but it's 3 times as common. So we have about 100 new cases per 100,000, or in this town, we may see somewhere around 250 or 300 new cases of PMR on an average year, which is a fair amount, actually, when you think about it. And again, all over the age of 50. But it doesn't affect Italians as often as it does Scandinavians, Czechoslovakians, and Germans. So that's kind of an interesting kind of sidelight. We got 2 up here, guys. Whoop, 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 whoop. Now I do have to use page up. Okay, this thing has been around for quite a long time, and the hallmark of GCA, or giant cell arteritis, is temporal headaches, arthritis that's in your head, right? Okay. And you can, in the old days, it was very obvious. People would have tortuous, swollen temporal arteries in the temporal areas. They were tender to the touch. Now, that's because in the old days they didn't have any treatment for it, and we catch people a lot sooner than that now, so we rarely see this intense inflammation that can occur along those blood vessels. Remember, it's an inflammation of the lining of the blood vessels. Not only is there a new onset of temporal headache, rarely it can be back here where the occipital arteries are. It interferes with sleep. You have scalp soreness, so it hurts to wash your hair or brush your hair, but mostly for me it's wash. Jaw claudication, that means when you chew your cornflakes in the morning, because the blood vessels feeding the muscles of chewing, the mastication muscles, are compromised. They're inflamed, so less blood is getting through those blood vessels. The muscles become sore almost immediately because they don't have enough energy. So you have to rest after 4 or 5 chomps and let those muscles relax till they get another bunch of blood, and then you can chew again for a little bit. So this is a sign that folks are having this inflammation of the blood vessels. It can even affect the tongue, and there was someone, I didn't see a person who's ever had this is pretty rare, but there was one where the woman couldn't talk anymore, and it did make some people happier until she got treated, then that got better. But the big scary thing is, if you don't get it treated, you can suddenly lose your vision, and it's just gone, and it won't come back. And 15% of people who have this disease will lose their vision if they don't have it treated. I have seen one woman who presented simply with a cough, and no one could figure out what was wrong, and it was this disease affecting the blood vessels to the voice box, and so that was causing a problem. It can cause problems with the blood vessels to the arms or legs. And I saw a lady today whose presentation wasn't headaches, but in fact it was when she raised her arm up over her head to comb her hair or to wash her hair, her muscles in her arms would become crampy and sore, and she'd have to put them down because the blood wasn't getting to those, and she had no pulses. Another reason this disease is called pulseless disease, because if 10% of the time, it'll affect those blood vessels going to the arms or legs. And remember, with the inflammation on the lining of the blood vessel, it can get so much swelling that no blood can get through. And so the downstream from those blood vessels, they don't get a good supply. Rarely there can be a stroke. But one of the things that I keep forgetting is that it can present without pain in the extremities with use, without headache, without visual changes. It can present in those over age 65, most commonly older folks, with just fever, loss of appetite, and just feeling terrible. And this is an uncommon thing to get sent to the arthritis doctor for, and eventually they do because their blood tests show inflammation, but nobody can find where the inflammation is. And this kind of process, they'll have a positive biopsy on the artery when we look, yet they don't have the classic features of giant cell arteritis. And this was brought home to me very recently with a lady who I couldn't figure out what was wrong. She already had rheumatoid arthritis. She had very high inflammation in her blood tests, but she just felt bad. I thought she was depressed. But I said, well, maybe this is giant cell arteritis. I gave her 20 milligrams of prednisone a day because she's a very little frail lady. And she came back to tell me that I'd gotten her life back. I mean, it was just overnight. She's better. It was impressive. Now remember again that they can present with polymyalgia rheumatica. We haven't defined what polymyalgia rheumatica is yet. And let's talk a little bit more about the blindness, because if we make the diagnosis early, we basically prevent the visual loss. Once they get on any dose of cortisone, it doesn't even matter if it's the right dose or not, the risk of having blindness falls to less than 1%. Now, there are other visual symptoms as well. About 30% of people can have a sudden loss of vision that comes back again. That's called amaurosis fugax. And about 5% of people won't have visual loss. They get sudden double vision, and it goes away. But once you lose your vision, the nerve that feeds the back of the eyeball doesn't have any blood, and it dies. And there's just no bringing that back, and you're permanently blind. I believe that when we do put people on high-dose corticosteroids to prevent this condition, they also need to be on a medicine that makes the blood thin, like aspirin. So I reinforce that. Now let's talk about PMR, polymyalgia rheumatica. 3 times as common, only in people age 50 or older, right? So over a period of a couple days, people will go from I'm okay to I am miserable. And that miserable is really a manifestation of stiffness and pain. The pain usually isn't the dominant feature, at least it wasn't when I was in Minnesota talking to Scandinavians. However, the German population in Nebraska seems to have more issues of pain with their stiffness. I think it's a cultural thing, I'm not sure. But nevertheless, they will tell you that they have suddenly developed significant pain and stiffness that's worst first thing in the morning. It's so bad that to get out of bed, they tell you a very characteristic story. They'll tell you they have to roll to the edge of the bed and let their feet fall off so their body can pop up. They actually can't get up any other way. And they could do fine the week before. The stiffness lasts for more than 60 minutes. It affects 3 areas of the body. It has to be at least 2 out of 3. Otherwise, we really can't make the diagnosis. It has to be the neck, the shoulders, and the muscles around the hips. So we call that the shoulder girdle muscles and the hip girdle muscles and or the neck, but 2 out of 3. And the interesting thing is when I touch those muscles, they don't hurt. They don't hurt. And the other thing that it is, it's not just one arm, it's always both arms. Always both arms equally. And that's important because a lot of us have rotator cuff disease. Many in this room I've seen have rotator cuff disease, and that's always asymmetric. And half of us finish the world without rotator cuffs, so that's a common thing. But the other thing is the night pain, and that is something that makes the night not only difficult to get out of bed, but difficult to enjoy a good night's sleep. They may complain of some subjective weakness. I'm so weak I can't, get off the toilet, that sort of thing. But it's really the stiffness and pain that they're describing. It's not truly weak when you test them. About 25% will develop rather prominent edema, swelling of their ankles, like water retention, not swelling of the joints. And about 40% will have I'm miserable, I'm fatigued, I'm feeling depressed, I don't have any appetite, I'm losing weight, I have that fever thing. Remember, we're talking about this kind of dwindles in the older patient. Now, these people will not necessarily have headache or visual loss, but they have about a 15% chance of having giant cell arteritis. The interesting thing that I teach people when they have polymyalgia rheumatica is if they can do this, we have it under control first thing in the morning. If I walked into your bedroom and knocked on your door and said, can you get your arms up like this? If I said, stick them up. If you can, the PMR is controlled. And that's important because we can't be running to the doctor all the time when we get an ache, because we have neck pain, we have shoulder pain, we have hip pain. 15% of all adults in this country will have hip pain at any one time. So we have to be able to distinguish polymyalgia rheumatica from life. Now, polymyalgia rheumatica, some of you have been diagnosed with this. And when you're being told that it's polymyalgia rheumatica, the first thing you should, as a doctor, think, maybe now after you've been to my lecture, think, is that that's a symptom. That's I'm stiff in my neck, shoulders, and hips, and I have a hard time getting out of bed at night, in the morning, and I don't feel good. But there are other things that can be like polymyalgia rheumatica, and it's your rheumatologist's job to go through those different things that it could be. For instance, it could be giant cell arteritis, and you hadn't really thought about that headache that's at your temples. Or it could be early rheumatoid arthritis, and about 15% of my patients who have PMR, when I pull away the cortisone, their arthritis flares, and it turns out it was rheumatoid arthritis all the time, just mimicking polymyalgia rheumatica. It could be something weird called RS3PE, which a friend of mine, Des O'Duffy, coined about 25 years ago at the Mayo Clinic, and that's a puffy man syndrome. They have polymyalgia rheumatica, but they have severe swelling of their extremities. I mean, really severe swelling of their extremities. And you give them a little bit of prednisone, it goes away. Sometimes associated with cancer, not so good. There's calcium crystal disease. We heard about gout. That's a uric acid problem. There's a calcium crystal arthritis out there that's becoming more and more common, and it can mimic polymyalgia rheumatica. Inflammation of the spine, I tell people frequently that there is no arthritis that causes neck pain or back pain. That's not quite true. 0.7% of all back pain is caused by arthritis. It's caused by this disease called spondylitis. Lupus usually doesn't affect the elderly, but systemic lupus erythematosus can occur in older women and older men. The oldest person I ever saw was 92 that got lupus, and it can look just like this. So you always want to check for lupus. Inflammation of the muscle, something called myositis, very rare. Only about 30 per million people get myositis. It's really a rare thing. Here's the funny thing about it. When your muscles are inflamed, it don't hurt. They don't hurt. You're just weak. Just weak like a kitten. You can't hardly breathe or swallow sometimes. And that's very scary, but inflammation of the muscle, the weakness, and I not feel good, could mimic the polymyalgia rheumatica. A lot of people are on cholesterol-lowering drugs. There's a whole literature now about the statin-associated muscle pains, and you have to work through that. Although I will tell you, statin-associated muscle pains don't usually give you neck and shoulder symptoms. They're almost always below the belt. If they are above the belt, they are worse in the lower extremities than they are in the upper extremities. So that's one of the clues. Hypothyroidism, obviously, if your energy levels are being sapped because you don't have a good thermostat and your thyroid's not good, that can be a problem. Depression is common, and it is something that can look like this, although they don't have inflammation on their blood tests. Cancer spreading to the bone, obviously that can be a very painful thing all over your body, and we have to distinguish that from polymyalgia rheumatica. Parkinson's, just from the stiffness. There is a disease where your calcium levels can get too high, and that can make your muscles very achy. Widespread pain, which is not an arthritis problem like fibromyalgia, is a mimic of polymyalgia rheumatica. It's important to recognize, though, that almost never starts when you're in your 50s. You have a history of not being achy and tired way before your age of 50. And most of those people. And then another weird thing, when you're vitamin D deficient, that you can have bones that hurt because they don't have enough calcium in them. So again, that clinical spectrum, we have the classic GCA, headache, visual change, jaw pain, stiffness. We have the classic polymyalgia rheumatica, prolonged morning stiffness, pain, neck, shoulders, and hips. We have the large vessel inflammation of the blood vessels, arms and legs, where the muscles become starved for blood and oxygen and they cramp with use. And then we have this kind of a wasting syndrome. I don't feel well, I'm not eating, I'm losing weight, and I got a fever. But they don't have the other stuff, and you always have to think about PMR and GCA. And here's a great picture. This is called a PET scan. When they put an MRI over it, PET scans are way too expensive for me to use in clinical practice. They're used in cancer a fair amount of the time, and you can put a radioactive tracer in the arm, and it goes to the places that are inflamed. And so here you can see the inflammation involving the entire wall of the blood vessel, and the great vessels are affected, the great vessels in their first branches. We call this sometimes a pulseless disease. We talked about that, the lack of blood supply to the extremities giving you that cramping. This isn't cramping like you go to bed and you get cramping. This is cramping where if you walk, you can only go so far, and it's always the same distance. Or if you use your arm, it's the same amount of work, and it'll cramp, and you have to put it to rest. The cramp goes away, and then you can do something again. It's real different than I got cramps in my legs at night. That's a different problem. And it's sometimes when the blood vessels are affected, you will get issues of decreased blood flow to the fingers, so Raynaud's phenomenon, or even ulcers on the fingertips. But here's one of the really weird things, is that even when I do a good job of treating this inflammation, and that's one of the beautiful things about these diseases, that they go into remission. Not like a rheumatoid where they're stuck with their disease forever. This disease usually goes into remission. And when it does, you think you're done, but you're not. Because the inflammation may continue in these blood vessels and we don't know it. And over a long period of time, Mayo will do chest x-rays, because Mayo is a leader in the descriptions of these diseases. I came from Mayo, so we'll talk about them. But one of my mentors actually recognized that there was a huge increase in the blood vessels in the chest dilating with time. We call those aneurysms. They're 17 times more likely to get a thoracic aortic aneurysm after you've been diagnosed with giant cell arteritis. There's a slightly increased risk with PMR. I really do think they're the same disease, just different spectrum. I really do. But in any case, the point being is that every 3 years or so you should get a chest x-ray, even when you're feeling good, to make sure that the blood vessel isn't dilating. Here's a great picture. In the old days, this was 20 years ago, before they had really fast CT scans that could look at blood vessels. What the blood vessel would look like, it comes off the aorta. This is the heart down here, and this is going up to the head. And these blood vessels that are affected by giant cell arteritis are the first branches and second branches off of the aorta because they contain elastic. Elastic allows the blood vessels to move with the pulse. When you get to smaller arteries in our arms and our legs, they don't move with the pulse. This elasticity allows you to have some sort of flexibility in the difference in the pulse pressures. But the thing is that unlike hardening of the arteries, which will look like something jutting into one side of the artery and blocking it, like a plaque or something, this has a smooth narrowing and then post-stenotic dilatation, smooth narrowing, almost like a string of beads. And you see that that's all inflammation, keeping it from blood from getting through and getting into downstream into the arms and to the fingers. And we used to have to do that to make the diagnosis. Now we just do the CT. It's probably more expensive. Here's that. Can you do this sort of thing? So again, when we're making that diagnosis, we're thinking about it because the folks are in the right age group, they have the right genetic predisposition, there's inflammation on the blood tests. We talk about thickened, tender arteries. I can feel them now. I've been doing it for 25 years. I can usually pick that up and know exactly which one to biopsy. We do get a temporal artery biopsy. That's the gold standard because you can't really trust my fingers, especially because the treatments are so hard on older people. They require very high-dose cortisone or prednisone to treat the inflammation initially, and we can make people sick just from that. So we really want to justify the fact that we have a disease that might cause blindness to justify those high doses of corticosteroids. The pulses will be abnormal sometimes, not always, like I said, about 10% of the time. They'll always have elevation in their blood tests, the SED rate and the CRP, one or the other, or most likely both. With that, they'll also present with anemia. If you did a PET scan, you'd have aortitis, and about 40% of the time, they'll have that inflammation and stiffness in the neck, shoulders, and hips that make it hard to get out of bed in the morning. So I know it's a lot of stuff we're kind of throwing at you here, but I figured the repetitive nature of talking about these will help. Now, why do we do the biopsy? A friend of mine, Steve Hall, back in 1988 at the Mayo Clinic did a study. What is the chance of you having giant cell arteritis if the biopsy is negative? And he found in 88 biopsies, only 9% of the folks had giant cell arteritis clinically. Everyone else had something else. Well, a third of them had polymyalgia rheumatica, so they're kind of related. But there were a number of other things, everything from other types of arthritis, headache, stroke, infections, even cancer, spreading to the bone and stuff. And so if you don't have, go ahead.
What was the negative tab? So they did not test positive for
temporal artery biopsy. So, and I repeated it here. So if the biopsy was negative, the temporal artery biopsy was negative, the chance of having giant cell arteritis is less than 10%. That's what you have to keep it in mind, but it takes it off the list for the most part. Because then you can commit, if they're positive, to a lot of cortisone, prednisone, for over a 9 to 18 month period of time, a long time. Now there's some biopsy controversies and we can talk about those, but typically I want 2 centimeters or more on one side. The biopsy is rarely complicated, but I've had people actually lose the little nerve that holds their eyeball up, their eyelid up, so that's not good. So you want somebody who knows what they're doing the biopsies. There is some people who, this goes back a long time, 1997, that said that they can do ultrasound without doing the biopsy and see the edema. It would be black because there's no water. There's no tissue there. It's just water around the artery because it's so swollen. But in my experience, that's way too operator dependent. You can't trust it. I still want that biopsy. At least in 2014, I do. We're going to get better at it. Remember that if you do have the large blood vessel involvement, the temporal artery biopsy doesn't necessarily rule out the disease. You have to do the angiogram or have to show the dye in the blood vessels like we did in that one case with the blood vessels going to the arms. The older you are when you're diagnosed with polymyalgia rheumatica, I just diagnosed a 79-year-old with PMR, the harder it is to say this is just PMR. It's more likely that they have giant cell arteritis, so you have to consider getting that temporal artery biopsy. Again, remember, it's a very abrupt onset, usually within a couple of days. I will tell you a story, though. I had a patient who was normal on the 8th hole of a golf course in Phoenix, and on the 9th hole of the golf course, they had to take him off in an ambulance because he couldn't move. It hit him that fast. So it can hit awfully fast. Neck, shoulders, and hips takes at least an hour to limber up. As long as you stay moving, you're doing a bit better. Sit down and watch TV, and immediately you gel. That's what we call it, and you're stiff again, and the clock starts all over again. Always over age 50. The youngest person I've ever seen with this disease was 49.7 years old. He was just over 49 and a half years old. Elevated blood tests are the sedimentation rate, or CRP. These are measures of inflammation in the blood. They can mean lots of things. We used to have a professor that said you needed a sed rate or a good doctor, but not both. In this case, I really want a sed rate to make this good doctor make the diagnosis. And finally, the last thing, in the PMR now, and that's not the inflammation of the blood vessels, that's just the stiffness, neck, shoulder, hips. That disease, everyone is 100% better. 100, not I'm 50% better, not I'm 10% better. I'm 100% better after 5 days of prednisone. And so if that's the situation, that we usually confirm the diagnosis of PMR with this test. We give them prednisone, and if they're not completely better, dancing in the streets and running back to give you a kiss and tell you I'm cured with their arms up like this, see doc, I can do that, they don't have PMR. They got something else. So what is PMR? Because we don't see joint swelling necessarily with it. It turns out the same guy who noted the RS3PE, Des O'Duffy, did a study way back in the 70s where he was able to show, and these are called joint scans, nobody does this anymore, but lighting up of the shoulders. So the shoulders are really inflamed. We just can't feel them because, you know, they're deep in there. On the little joints I can feel real good. On the shoulders it's very hard to feel that. So it's an inflammation of the lining of the hips and the shoulders. And so how do we treat it? So let's talk about the blood vessel inflammation one first, the giant cell arteritis. We do want to make sure that you're on the low-dose aspirin so the blood is thinner. It's real important that I get support from your primary care provider so that we're treating the cholesterol. Because basically when you have so much inflammation in your blood vessels, it's like accelerated hardening of the arteries. It can happen very quickly. You'll lay down a lot of cholesterol in your blood vessels. So we need to have those cholesterol tested. If you have questions about this, your doctor should whip out their phone and use the app that allows you to use the something treatment protocol. Can't remember what the A is. ATP4 guidelines, which came out last November, and you just put in the cholesterol, the age, and all their blood pressure and stuff. You push a button and it tells you whether you should be on cholesterol-lowering medicine. If they're not doing that and they're saying, hey, it looks high, take something, you say, what about those ATP4 guidelines? Am I really supposed to be on this stuff or not? Because you're committing yourself, if you're a young guy, you know, you're committing yourself to 50 or 60 years of something that we don't know what happens to you if you take it. The other thing is that you got to stop smoking because, again, this is like accelerated hardening the arteries. It's like 20 years worth of hardening of the arteries in 5 or 6 months. So we also want to control blood pressure and diabetes, which gets harder because we got to whack you with about 60 milligrams of prednisone a day initially, and that's industrial strength prednisone. You're not going to like it. You'll like it the first day. You'll like it the second week when you come to see me because you feel great. But when your face starts getting wide and you can't sleep at night and you're all jittery, you're going to say, why am I on this? To prevent blindness, I'll say. Oh, that's why. Okay, so I'll stay on it. And everyone should get bone protection. When you're 65, no matter whether you're male or female, whether you have a normal bone density or don't have a normal bone density, when you get on that much prednisone, you need to be on something to protect your bones. Like Fosamax or one of those other drugs, but I'm a big fan of generic Fosamax. I still think it's the safest one out there. And there's good reasons for why it's preferred for a number, because it lasts in your bones for up to 10 years. So you can go on holiday. Nobody knows what to do with a drug that has a 200-day half-life. Okay, so remember we talked about the biopsy. Well, what if it's Friday afternoon and you've come to my office and I go, hey, that sounds like giant cell arteritis. We need a biopsy. Do I say I won't treat you until I get the biopsy? No, I'll treat you, and I have up to 10 days to get that biopsy. Anything past the 10-day mark, however, the inflammation starts to go away, so we might miss it on the biopsy specimen. But remember, anytime I get you started on the prednisone, the risk of the blindness starts to fall right away. We keep on the same dose of high-dose prednisone until the inflammation indexes are all back to normal. Usually takes about 2 weeks, and then I start peeling it back really slowly. 9 to 18 months it takes me to get off the prednisone. And almost always we do get off the prednisone, I have to say, if we go too fast. And a lot of the docs make the mistake of giving people a Medrol dose pack or something where they feel good for a couple days and then they pull it away right away. Well, when you do that, the clock starts all over. If you come off too quickly in the 3rd month, well, now that 18 months just got started all over again, which is a pain. So nobody likes to do that, so we go really slowly. We don't, if the PMR gets worse, the neck stiffness, pain in the shoulders and the hips, we usually don't go back up on the prednisone. We just hold that dose for 4 weeks, and typically everything settles down. What can I use besides prednisone? Not much. This is one of them diseases where the arthritis therapies that we use, the rheumatoid arthritis therapies, don't work very well. Yep.
Is dexamethasone a very good substitute for the prednisone?
Well, it's a very good substitute for the prednisone. The problem I have with Dex is that it has probably between a 25 and 35 hour half-life. So it stays in your system a lot longer. Prednisone has a 6-hour half-life. And so I just think we complicate the steroid side effects. Everything from not being able to sleep to stealing calcium from the bones is going to be accelerated even more with Dex.
Okay, if you're getting the dexamethasone because you also have insulin-dependent diabetes, and you're told that the Dex doesn't interfere with blood sugars as much. Is that the case or not?
I don't think so. The problem, you know, it depends on the dose of dexamethasone. 0.75 milligrams of dexamethasone equals 5 milligrams of prednisone. So whatever dose they pick will affect the sugar. These are very potent sugar enhancers because they're called glucocorticoids, and there is no less glucocorticoid effect of dexamethasone. It's just that they're maybe picking a lower dose. I've had a few patients that didn't like the peak of prednisone and then it leaves again. That's kind of like a shot of adrenaline, and then because it's a stress hormone. See, when we're getting chased by a bear, if that was to happen, for instance, what was it? There was a lady in Florida who was beat up by a bear just last week. So this is important to know. There wasn't it? I mean, I'm pretty sure. So if we're being chased by a bear, there are several things that are part of what we call fight or flight. Either we fight the bear or we get the hell out of there. And that kind of fight or flight sort of thing includes adrenaline. Okay, so our heartbeat gets better and we get tight blood vessels, so all the blood gets back to the heart quicker, and we pump to the brain and we don't pump the gut and all that sort of thing. And the other thing that happens is we pour out cortisol, because it is a stress-related hormone. It actually seals the blood vessels and makes it so they're not leaky, and it makes them more responsive to adrenaline. So that we want that high cortisol level. That's really good. But the longer we're on high doses of cortisol, the more we become fatigued, have higher blood sugars. We have the problems of cataracts, the high blood pressure, steal calcium from the bones. It gets us into all kinds of trouble too. So it's clearly a double-edged sword. But we got to use it, because here's the thing. Rarely, now there's been one study that showed that methotrexate worked a little, and there was another study that showed methotrexate didn't work at all in this disease. I use it. I think it works better than the way that people describe. I would bet 80% of the time I'm able to use methotrexate to reduce the requirement for prednisone. And whenever a person flares, you know how we talked about the clock starts all over again? If it starts all over again, I always use methotrexate the second time to kind of make it easier to reduce the prednisone. There's a new drug called Actemra. It's just $34,000 a year. And there are 7 patients who have been reported who have been treated with this, and they did great. They were able to reduce their average dose of prednisone from 21 to 4. But remember that over time I'm able to do that anyway, so I don't know how important that is. And at autopsy, because one person had a heart attack, they still had active vasculitis. And I don't know how important that is either, because remember we said that people who we think we've treated well will still have dilation of their potential dilation of their thoracic aorta. So maybe a lot of people have that. That may not be a big deal. I have put one person on this so far, and it's worked very nice. It's a tough thing to sell, though, because there's no FDA approval for this drug, only for rheumatoid. So they have to have both, one way or another. Nothing else works. None of the other fancy drugs that I have work for this disease. What about PMR? That's the one where you don't have the blood vessels, but you could have it. 15% of them could, but they have that stiffness in their shoulders, their neck, and their hips. Usually we use 20 milligrams of prednisone, so that 1/3 the amount that we use for giant cell arteritis. A lot of docs like every other day steroids because there's less side effects from that. Doesn't work. Can't do that. We have to protect the bones just as much. There's a rare person that can get by just with the naproxen or ibuprofen. Rare, rare, rare. I haven't seen that probably in 15 years. You taper when the inflammatory parameters and the symptoms are gone. Typically, in the first 2 weeks, they'll be back to tell you and want to give you a hug because they feel so good. I mean, you really feel like your life is no longer any fun. What about, you were going to ask?
A man with prostate cancer, can they be treated with prednisone?
Absolutely.
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 Is that effective with testosterone?
Not at the doses we use for PMR, but for 60 milligrams of prednisone a day, it can actually lower your testosterone in your system. So that's not a bad deal. Actually, with prostate cancer, we want less male hormone running around anyway. Yeah. We have to treat anywhere from 9 to 15 months, too rapid a taper, and the clock starts again. Even then, about 1/3 of the people who we treat successfully will flare within the first 10 years after the disease. So you always have to keep that in the back of your mind, even if you get dismissed, or I call it graduating from the rheumatologist. So when you get to go home and not come back to see me, you still have to keep that in mind, and you may end up being back to see me anyway. Those people who tell me they have PMR and 2 years later they're still on 5 or 10 milligrams of prednisone a day, it ain't PMR. In my opinion, they've missed the swollen joints, they've missed the vasculitis, they've missed something. And so I usually find that to be, it's got to be something else. Like I said, 13% of people will have an inflammatory arthritis that's missed, and 15% will have the inflammation of the blood vessels. And that taper, remember, we're only going to see them every couple of months, so how does the patient know their joints are they're still doing good? They do this, right? That's how they know. Every day they do this. When they can't do that, they got to call. Oop. So what are the outcomes? Most everybody goes into remission with GCA, but 1/3 relapse in the first 10 years. The thoracic aortic aneurysms we talked about, chest x-ray every 3 years, that's what I do or recommend. Your doctor won't remember that. So you have to be the advocate for your polymyalgia and your giant cell arteritis. And you have to mention that again.
You're talking about your general physician.
Well, because if you're dismissed, if your inflammation is well controlled, and you're 10 years from the last time you took prednisone, and your GCA or your polymyalgia rheumatica is well controlled, you still want to get that chest x-ray every 3 years to look for dilation of the blood vessels. In the PMR, most patients will enter remission. They say 50% are off all steroids by 18 months. The ones that are not have something else. That's been my experience almost always. I can tell you what it was in a couple cases. It was diverticulitis. You know, it wasn't anything to do. Their SED rates remained high. They still had achiness, and the physician who was treating them couldn't separate regular old garden variety, I'm achy and I'm 70, from polymyalgia rheumatica. Remember, that's how you tell. So you got to know how to do it, and you got to do it right. All right. And we talked about that, kind of hammering that home. So in summary, these are really complex diseases. They're a little more fun than a worn-out knee for me. So I mean, I might get a little more excited about this than a knee. But the other thing about this is that the rheumatologist probably should always be part of the management team, because you have to know this stuff. You have to have seen it. You have to have been treating it regularly to appreciate when people say, I think I'm flaring or I'm not flaring. How do you interpret those things? How do you, like I said, justify high-dose prednisone if you haven't gotten the temporal artery biopsy? A lot of people don't want to put the patient through that extra hassle, but we do, because it's the right thing to do. There's going to be some very exciting new things coming around the corner, I think. We're going to be seeing more information about what sets this off. Remember, we talked about a season. There's a PMR season. The Mayo Clinic really feels there's a virus out there that's contributing to this. They're searching very hard. For quite a while, they were looking at parvovirus or dog distemper virus. They haven't nailed it down yet, but they will, and they'll figure that out. I think it will be helpful to have that information.